All right. Hello, I'm Sarah Mackie. I'm a rheumatologist from Leeds, UK, and I want to talk to you today about a case of a 76-year-old lady who has PMR, polymyalgia rheumatica. So I know she has PMR because I'd seen her before. She had a really typical presentation. She responded to steroids in just the way we expect for PMR. She tapered her steroids down, and that all happened in just the way we expect for PMR. But then I call her up for a routine review, and she says, "Doctor, I can't get below 5 milligrams of prednisone. Every time I try to get to 4 milligrams, my PMR pain comes back and I'm full of pain and I can't do anything." So what do we do? So the first thing is we need to get her up to clinic so that we can take a look at her and she can show me what it is that her symptoms are. So we come up to clinic and it turns out that in fact her shoulders and her hips are absolutely fine. And where she's saying that her PMR has moved to is her first carpal metacarpal joint of both hands and some of her Heberden's nodes. There's no sign of fibromyalgia or any other inflammatory arthritis going on either. So what do I think about here? Well, the story as I'm telling it is pointing you very much in the direction of, well, this is unmasking of hand osteoarthritis as steroids are tapered. And this is something we're really familiar with in rheumatology practice. But just before we rush into that, I want you to think one thing, and I want you to ask this lady about symptoms and signs of giant cell arteritis, because just sometimes, just occasionally, this is the first warning sign that we have that PMR is flipping over into giant cell arteritis. So it's worth just asking about symptoms and signs and checking a CRP. We've already had a think about other potential rheumatic diseases, other inflammatory arthritis, doesn't have any of those, so that's fine. The other thing that sometimes we think about is whether this lady, maybe a year into steroids, may have developed iatrogenic adrenal insufficiency. So what we tend to do is we tend to request a 9 o'clock cortisol blood test. So she has that blood drawn 9 in the morning, 24 hours after her last prednisone dose. And if that value comes back very low, then we may refer to endocrinology for some more testing of her endocrine axis and to figure out what the best plan for her is. But assuming that that comes back okay, then we treat the hand osteoarthritis. So we educate her, we explain what's going on. Hand strengthening, grip strengthening is incredibly important because long-term steroids really impair your muscle strength, and that can be very insidious and creep up on patients without them realizing. So muscle strengthening is absolutely crucial in this situation. Symptomatic management of the pain, and really just understanding what it is that's going on. In terms of the prednisone taper, it may be that that 1 milligram drop from 5 to 4 was just too much for this lady, and she might need to drop by 0.5 milligrams. She might need to cut her tablets or alternate doses day to day. There are very slow prednisone tapers that are available that are a little bit more gentle than the standard drop by 1 milligram every month. And sometimes those slow tapers work where other tapers do not. And that can also be useful for relapsing PMR or relapsing GCA as well. These slower tapers, sometimes it seems to be the reduction in the dose that unbalances things and makes things flare. And sometimes we can get away with slower tapers and get to a smaller dose if we reduce in the prednisolone dose a little bit more gradually. So that's what I wanted to talk about today. When you have your patient who's not very happy as they're tapering their prednisolone with PMR, yes, it is quite often osteoarthritis, but just occasionally it's giant cell arteritis. So don't forget to ask about those symptoms and look for those GCA signs. Thank you very much for your attention today.